Great. So thank you to the organizers for inviting me. I'm going to focus only on Crohn's disease, and I think Steve Hanauer follows me, focusing on advances in ulcerative colitis. There'll be a little bit of overlap for an agent or two, but mostly different. So here's a little overview of what we'll try to cover in the next few minutes. Azathioprine is an old drug, but there's some recent advances in what we know about its efficacy. So I would just want to highlight those. To talk a little bit about an evolving concept of deep remission and treating to target, and then we'll talk about some new agents both in the mild to moderate Crohn's category and the moderate to severe category where a lot is going on. So let's start with our old friend, azathioprine. If you go back to the 1970s and 80s, it was very controversial whether azathioprine was effective for Crohn's disease. The National Cooperative Crohn's trial showed that it was not effective, and a trial from the Mount Sinai Hospital led by Dan Present and Bert Korolitz showed that 6-mercaptopurine was effective. In the 90s, people eventually accepted that there was some benefit, particularly for steroid sparing, and there was an important pediatric trial, the Markowitz study, that showed in about 50 children and adolescents that early 6-mercaptopurine would be effective for steroid sparing in childhood onset Crohn's disease. So this year, two large trials from Europe, one from Spain and one from France, this is the French study, were published looking at so-called top-down therapy with steroids and azathioprine versus steroids alone, and then escalating up to azathioprine in a step-up fashion if you need it in patients with early onset Crohn's disease. And here you can see over the course of several years that there's really no difference between azathioprine and placebo in the rates of maintaining remission over time. And then here's another trial from Spain, similarly designed. So this is new diagnosis of Crohn's. It's really the adult version of the Markowitz trial. And you can see no significant differences for steroid-free remission sustained, and if you went into remission, of survival-free relapse. So as you go through the course of the week, you're going to hear other discussions about the safety issues related to azathioprine. But I think these data should make you think carefully about your use of azathioprine monotherapy. This is a different discussion from the additive value of azathioprine in a combination setting, but you should think a little bit carefully about use of azathioprine monotherapy in patients with Crohn's disease. There's evolving data about the concept of treating to target. So we all do this in practice. The clinical trials freeze everything and they compare drug to placebo and show that the drug is better than placebo or not. But in the real world, there's multiple moving parts, and you don't just do one cycle of therapy if you don't get it right. You check the drug level, as we're going to hear later this morning, and adjust the dose. You might add a drug. You do all kinds of things of adjustment. So this concept of measure, make adjustments if you don't reach your treatment goal, measure again, make more adjustments if you need to in a sort of cycle is called treat to target. And this comes from rheumatology, and it looks like it fits pretty well with Crohn's disease. And over the course of the next year, you're going to hear more about what's possible with treatment algorithms as opposed to just a single intervention. So this is, I think, a new concept that you need to think about positioning in the Crohn's disease world. Let's look at some of the individual agents that are coming along. We haven't had anything new since ileal release budesonide for the mild to moderate Crohn's population, so it's been kind of a decade. So this is an interesting study. The rifaximin that you're used to using in the bacterial overgrowth and hepatic encephalopathy setting is a chirally mixed rifaximin formulation. So this formulation is a more chirally pure formulation, and then it's in an extended release formulation delivered to the ileum and colon with the idea that having this pure formulation locally delivered might be beneficial for Crohn's disease. And what you can see here is a nice response for the lowest two doses, and then there's kind of a U-shaped dose response curve at the highest dose. And they've gone back and done some more preclinical work, and it looks like the highest dose could potentially be a pro-inflammatory effect. So this is going to go into phase 3 testing very shortly at those lower doses. And I'm optimistic that this might, over time, lead to a new therapy for mild to moderate Crohn's disease. Then there's an area that's quite exciting, and this is as opposed to TNF blockade, which we've spent the last decade and more kind of working on, lymphocyte trafficking as a treatment for Crohn's disease, and I'm sure Steve will talk about this for ulcerative colitis as well. So the idea is if you can keep lymphocytes from trafficking from the vasculature into the gut wall, then they won't make the pro-inflammatory cytokines that lead to inflammation. There's a couple of ways to do this. One is with blocking antibodies to alpha-4, which blocks both alpha-4 beta-1 and alpha-4 beta-7. So the drug you might be familiar with, Tysabri, does that. And you can think of this as a kind of pan-body lymphocyte trafficking blocking agent. So it has the unfortunate side effect of blocking lymphocyte trafficking to the brain and predisposing patients to progressive multifocal leukoencephalopathy, or PML. So although Tysabri or natalizumab is approved for Crohn's disease, it hasn't been used very much because of the PML risk. And everyone's been very interested and excited about the idea of developing a local or gut-selective strategy for blocking lymphocyte trafficking to the gut, leaving trafficking in the rest of the body intact. There are several such drugs. I'm going to talk predominantly about vedolizumab, but I'll touch on etrolizumab as well. So vedolizumab is anti-alpha-4 beta-7. Again, that interacts with MAdCAM-1, leaves the alpha-4 beta-1, VCAM-1 axis in the brain intact. Another strategy is to block MAdCAM-1 on the gut vascular endothelium, or to block the beta-7 subunit. So we'll talk first about vedolizumab, and just to give you a picture of the bigger world. So the trials that I'm going to show you and that Steve will show you in a few minutes led to an FDA advisory committee on Monday of this week looking at both ulcerative colitis and Crohn's disease, and the advisory committee members recommended approval. Now that's not a binding decision to the FDA, but they usually follow the committee's advice. So I think we're anticipating the availability of vedolizumab in the United States later this year or early next year for both Crohn's disease and ulcerative colitis. So vedolizumab is a monoclonal antibody against alpha-4 beta-7 integrin. The Fc receptor has been altered to abrogate its effect with respect to complement fixation. It's given intravenously as about a 30-minute infusion. Here's some phase 2 data published several years ago by Brian Fagan. And if you look over at the right at clinical remission with a couple of different doses versus placebo, you can see an inductive effect for vedolizumab in patients with Crohn's disease. And here's data looking over the course of a number of weeks from that same trial, and you can see this nice dose response between the two doses and just a progressive accumulation of effect. Now, the other thing to say in retrospect is you can see that those lines have really not clearly plateaued yet. And I think we're learning as we go on with the anti-integrins that you probably you can see a clinical effect that you can measure and can be statistically significant at 6 weeks, but you probably have an accumulation of clinical benefit out to about 10 or 12 weeks or so. So then we moved on to a phase 3 development program. Steve will show you in a few minutes the data for ulcerative colitis, but these are the data for Crohn's disease. So first was a phase 3 induction study, and this study was set up with 2 primary endpoints, and statistically you could either be at the p equals 0.05 level at both endpoints or p equals 0.025 at one endpoint for the trial to be positive. And you can see that the less than 0.025 endpoint was met for remission, so the induction trial was positive by those criteria. And then patients who responded to vedolizumab were re-randomized to continued vedolizumab administered as 300 milligrams every 4 weeks or every 8 weeks, or placebo. And here you can see a robust maintenance effect among the patients who were week 6 responders for clinical remission, clinical response, and most importantly, steroid-free clinical remission relative to withdrawing the vedolizumab. About half of these patients were anti-TNF failure patients, and the rest had failed steroids and immune suppressives. So this is that kind of difficult to treat patient population, including the anti-TNF failures that we all struggle with in practice, and why we're so interested in having another option to treat. There's some other drugs in this class, as I said, anti-MAdCAM1, which is under development currently, etrolizumab, anti-beta-7, and there's a second anti-beta-7, AMG 181. Switching gears now to anti-cytokines. So of course, anti-TNF agents are antibodies against the cytokine tumor necrosis factor. There's another cytokine, interleukin-12 and interleukin-23, which are kind of upstream pro-inflammatory cytokines, and they share a subunit, P40. So ustekinumab is a monoclonal antibody directed against the P40 subunit that is shared by interleukin-12 and 23. This drug is currently approved for psoriasis. It's quite effective in psoriasis, and it's in phase 3 testing for Crohn's disease. The phase 3 testing came out of the 2 clinical trials that I'll show you now. So the first trial was a phase 2A trial in kind of a mixed population of patients, some who with active Crohn's disease, some who had previously failed anti-TNF therapy, and some who hadn't. And you can see overall in the far upper left corner a benefit in favor of ustekinumab over placebo, but the difference wasn't significant at 8 weeks. However, if you looked at the subset of patients who had previously failed anti-TNF therapy and where the placebo rate was lower, then you could see a significant effect throughout the 8-week dosing interval. And then if you look at change in CRP in that study, there really wasn't a change in CRP in the 2 bar graphs to the left. And conversely, with both subcutaneous and intravenous ustekinumab, you could see a reduction in CRP between baseline and week 8 amongst patients who got ustekinumab. This led to a phase 2B clinical trial of intravenous induction therapy with ustekinumab at 1, 3, and 6 milligrams per kilogram, and you can see that all of these doses were effective at driving a 100-point change by week 6 and week 8 in Crohn's disease. The remission rates were lower, and I think that takes time to accumulate. This was really a train wreck patient population. Half the patients had failed 2 or 3 anti-TNFs. Median CDI scores were in the mid-300s, so many patients had a long ways to come down. And as you go further along, then some of the patients will come into remission. We took the patients who had responded to induction therapy with vedolizumab and re-randomized them to ustekinumab or placebo. And here you can see that you can eventually achieve remission amongst the responding patients if you continue out to about 6 months of treatment. And this is now in a big phase 3 induction and maintenance development program. Tofacitinib, if you read the New England a year or so ago, there was a nice result of higher dose tofacitinib for ulcerative colitis. Steve will probably talk about that. And we were interested in this for Crohn's disease too. This is an oral molecule currently approved for rheumatoid arthritis that blocks various Janus kinase receptors, particularly Janus kinase 1 and 3. So in Crohn's disease, it was a 4-week trial, relatively small, about 25 patients or so per arm, and you can see that there wasn't a clear signal for efficacy even at the highest dose of 15 milligrams twice a day, although there was about a 12% delta. So it's a little hard to tell, and the placebo rate was relatively high, placebo response rate of 28% at 4 weeks. So it's a little hard to tell, does this not work in Crohn's disease? Did we have the wrong patient population with this high placebo early on? We did see at the highest dose very clear reduction in CRP under the 15 milligram dose that then bounced back after tofacitinib was withdrawn. So I think this shows evidence of a biologic effect, and a large phase 2B trial that is really taking some steps to manage the placebo rate is currently underway, and I think we'll have a better feel for that in the next year or so. Tocilizumab is currently approved for rheumatoid arthritis. It's an interleukin-6 receptor antibody. A small pilot study showed evidence at the higher dose of benefit for remission and response over a month. There are a couple of drugs, Bristol-Myers Squibb has one, as well as Pfizer, looking at interleukin-6 as opposed to the interleukin-6 receptor that I just showed you, and we should have more information about this over the next year or so. Lastly, an antibody against the chemokine interferon gamma inducible protein, or IP-10. There's a trial underway with that. We should get a data readout on that over the next year. So there's a number of things in development, and in conclusion, I hope you'll rethink a little bit your use of monotherapy with azathioprine for Crohn's disease. Think about these evolving concepts of treating to target in Crohn's disease and treatment algorithms as opposed to single drugs. There's lots of things that are interesting, but the thing that's really on the near-term horizon, and you're going to, by this time next year, you'll be using it in your clinical practice, is anti-integrin therapy with vedolizumab. Thank you. Let's stay up here.